Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of actually having on the podcast Dr. Alex Melamed from the Division of Gynecologic Oncology, Department of Obstetrics and Gynecology at Massachusetts General Hospital in Boston, Massachusetts. He's also, of course, one of our associate editors. And today we're going to speak about an important article that was published in JAMA Network Open, Neoadjuvant Chemotherapy, Case Volume, and Mortality in Advanced Ovarian Cancer. Alex, thank you so much for accepting our invitation to speak on the podcast. Really looking forward to this discussion. As always, I learned such a great deal from you every time we talk, so I'm really excited about going through the details of this paper.
Oh, Pedro, thank you so much for having me. It's always such a pleasure to talk to you. And, neoadjuvant chemotherapy for ovarian cancer is one of the topics that I'm most interested in and always really excited to get to talk about it.
Fantastic. So let's actually start by discussing what was the initial impetus for exploring this question. In other words, why did you think this topic was important? And what specific question was unanswered in the literature that you felt that this would fill that gap?
Yeah, well, so I've been really interested in studying neoadjuvant chemotherapy for advanced ovarian cancer for a long time, and it's a question that I and close collaborators, you included, have looked at from different angles. I had really come to the conclusion based on the randomized evidence and the observational work that we had done that that it's overwhelmingly clear that patients with advanced ovarian cancer don't seem to be harmed by getting neoadjuvant chemotherapy in terms of their long-term outcomes, and that many patients have benefits in terms of short-term outcomes. But I know that not everyone believes that conclusion the same way that I do. And so the question that came to my mind was, in what settings is neoadjuvant chemotherapy the most beneficial, right? In what settings is it the most important that physicians appropriately pick patients to get neoadjuvant chemotherapy? And there was a paper probably like 10 or 15 years old in JCO, led by Dr. Jason Wright, that had found it was a paper about failure to rescue in ovarian cancer surgery. And it was about for patients who have a complication after ovarian cancer surgery. Who ultimately does okay, and who ends up having a severe, who ends up dying after surgical complication. And this paper demonstrated that low volume hospitals really had a high rate of failure to rescue. So while the rates of complications weren't that different, at higher volume hospital, patients tended to be all right after complications, whereas at lower volume hospitals, those complications appear to spiral and lead to patient mortality. And this led me and Dr. Katie Abel, who was the first author on this paper, to come up with this hypothesis that if anywhere it was important to use neoadjuvant chemotherapy frequently, it would be at low volume hospitals where the consequences of a complication after an upfront debulk could be more dire, more severe than in a hospital that was more equipped to deal with those complications.
Well, excellent. Thank you for that introduction. And before we get into the study design, Alex, I wanted to ask if you could just speak a little bit about the National Cancer Database. You use this for this study, particularly for our international listeners. What information does it offer that specifically worked with your study question?
Yeah, so the National Cancer Database is one of two major cancer registry databases that are available in the United States. One that maybe more people may be familiar with is SEER, And SEER is a population-based cancer registry. So SEER includes information from geographic regions in the United States that is complete. So if you live in a SEER region and you get upfront treatment for any kind of malignancy, you're going to end up in the SEER registry. And what is going to be there? Well, we're going to know about some demographic things about you, your age, your ethnicity. We're going to know some things about we're going to know some things about the histology of the cancer that you got, the stage. We're going to know what kind of surgery you had. We're going to know whether or not you got radiation or chemotherapy as the first line of your treatment. And we're going to know about your overall survival. So that's the kind of information that is in there. Now, the difference between SEER and the NCDB is that rather than being population based like SEER, NCDB is hospital based. So NCDB includes the same information, but it isn't for specific geographic regions of the United States. It is for any hospital that is accredited by the Commission on Cancer. And this happens to be a lot of hospitals. So almost 1,500 hospitals in the United States are accredited by the Commission on Cancer. They treat about 70% of all new cancer diagnoses. And any hospital that has this accreditation has to contribute all of this registry data to the NCDB. And the reason that it makes this the reason that this database is so appealing for my particular question is that my question is a hospital-based question. I'm interested in high volume hospitals compared to low volume hospitals, and NCDB has identifiers for what hospital you're treated in. There, you can't identify specifically, but it is a an encrypted identifier, so you can identify low volume hospitals, you can identify high volume hospitals, and you can also see how practices at each hospitals vary from one another.
Fantastic. So now let's get into a few questions about one of your favorite topics, study design. So in your study design for this particular study, you had two exposures of interest. Can you tell us about the details of these exposures and why you chose these?
Yes. So, the two exposures that we had in this study, one of them was one of the exposures is obviously the rate of neoadjuvant chemotherapy that is given at a hospital. And so what we were really trying to capture was this phenomenon that different providers, different practices tend to administer neoadjuvant chemotherapy with a different level of liberality. So there's some places in this country where almost anyone who has an obviously stage 3C or higher ovarian cancer, they're going to get neoadjuvant chemotherapy. People aren't even really considering primary debulking surgery, and there are places where most patients who have a stage 3C or 4 cancer are still going to get a primary debulking surgery. And so we were interested in defining every hospital by the proportion of advanced stage ovarian cancer patients there who receive neoadjuvant chemotherapy. So that's one of our exposures of interest. And the other exposure of interest was, on average, how many ovarian cancer patients does each of these hospitals treat a year? And we were really interested at looking at the intersection of these two exposures into how they are associated with ovarian cancer mortality, primarily in the short term, so within 90 days of surgery, but also in the long term.
Okay. Now, Alex, as you know, we often have questions from our fellows, and this question is still on your study designs. This is from Matteo Lovero from Policlinico Gemelli in Rome, and he's asking, in your study, the primary endpoint was 90-day surgical mortality, but you referred to it as a standardized 90-day mortality rate. Could you walk us through exactly what that means, and how did you construct this endpoint, and why was it important to standardize mortality rather than just report the crude 90-day death rate?
Yeah, that's a great question. So, you could do this study looking at just 90-day crude 90-day mortality, but what that wouldn't account for is that uh, different hospitals have different case mixes, right? So it's not like hospitals have take care of a random sampling of the population. Hospitals are in different neighborhoods. Some hospitals are safety net hospitals, some hospitals are privately owned, some hospitals are academic, and all those hospitals are going to be seeing different patients on average. And so, what the standardization of the 90-day mortality does is that it basically adjusts for the measured differences in the case mix between the hospitals. And it's very closely related to a methodology that I think people may be familiar with, which is a ratio between an observed and an expected mortality, right? And so what we basically do is we say, based on, the particular mix of patients that this hospital took care of, what would we have expected for the number of cases of 90-day mortality that we would have seen? What was the actual number of deaths we saw? And then you use that ratio to calculate this expected versus observed ratio. And then you just multiply that ratio by the average death rate in all the hospitals. And that's what gives you this metric of adjusted 90-day mortality.
Excellent. So now let's get on to the results. I believe 70,707 patients were included. Tell us what the highlights of your results were.
Yeah, so the results were a little bit surprising, actually. So we did not find the finding that we expected to. So, what we ultimately expected to find was that, the difference in 90-day mortality would be greatest from the hospitals that did a lot of neoadjuvant chemotherapy to the hospitals that did very little in the low volume hospitals, right? That was our hypothesis. That in these low volume hospitals, if you only did primary debulking, you were going to have highest the highest 90-day adjusted 90-day mortality rate, and that you'd be able to get that down low by doing more neoadjuvant chemotherapy. But what we actually found was that the first part of that assumption was true. So the highest mortality rates we saw were indeed in the low volume hospitals that did a lot of upfront debulking surgery. But what we found was that the mortality rates never fell below a certain threshold in those hospitals, no matter how much neoadjuvant they did. So neoadjuvant chemotherapy did seem to drive down 90-day mortality, but once you got to about a 90-day mortality of about 4%, it didn't seem to get any lower. Right. Whereas at the highest volume hospitals, we saw that it seemed like there was almost like a continuous relationship. Like the more neoadjuvant chemotherapy you did, the more the 90-day mortality seemed to fall. And the lowest mortality rates we saw, the very best outcomes that we saw, were in the high volume hospitals that did the most neoadjuvant chemotherapy.
So really, very interesting findings, and I think we would like to get into some of the details of that. Many of them with the questions from our fellows. So we're going to get started with Masha Pervan, University Hospital in Munster, Germany, and she's asking: neoadjuvant chemotherapy rates between low, average, and high volume centers in your data were 42%, 37, and 43% respectively, and were deemed significantly different. What do you think are underlying reasons here? What was the impact of selection criteria for interval versus primary debulking?
Yeah, so one of the things we really don't have with this kind of database is an understanding of what anybody's thinking, So we don't know what the criteria are at each of these hospitals. All we can say is, this hospital gives, 60% of their patients neoadjuvant chemotherapy, and that hospital gives 20% of their patients neoadjuvant chemotherapy. So that definitely is the limitation. One thing I would say is that those rates are not that different from one another, right? Between the low, medium, and high volume hospitals, right? It's like a 5 percentage point spread. When you look across all the hospitals, there's hospitals that are doing, 70, 80% neoadjuvant chemotherapy, and there's hospitals that are doing 10, 20%. So what I would say is while there is that statistically significant difference, the absolute difference in the use of neoadjuvant chemotherapy is not that large. I could come up with some reasons why I think the lowest volume and the highest volume hospitals use it the most. I think the highest volume hospitals use it the most because they're the most expert and they follow the evidence the closest, and the evidence really supports using neoadjuvant chemotherapy. And I think the lowest volume hospitals actually use it the most because they probably get the very sickest patients, right? The lowest volume hospitals, a lot of them, don't want to be taking care of neoadjuvant of ovarian cancer, and when they're doing it, it's because they're getting someone who's in real extremis or someone who can't be transferred for insurance reasons and so forth. And so they may be having the most patients that are truly, truly not candidates for upfront surgical treatment.
Yeah. And a follow-up question from Masha as well is, did you have data on complete resection rates? I imagine they're not reported in the NCDB, but are those not important confounders for survival outcomes?
So the NCDB does report actually cytoreductive results. It is not a complete, it's not a completely reported variable. So I think the last time I looked, about 60% of patients in the data who have debulking surgery, we know what their cytoreductive status is. So it's okay, but obviously 40% is a fairly high percentage of missing data. I know that people think of this as a confounder. I don't think of it as a confounder because I think of it as very much a mediator of the of this. Obviously, when you do neoadjuvant chemotherapy, you get much higher rates of complete cytoreduction. That doesn't mean that complete cytoreduction is as prognostically important after neoadjuvant chemotherapy as it is after upfront debulking surgery. The rate of the complete cytoreduction, the completeness of cytoreduction is a variable that really incorporates a lot of things. Obviously, it incorporates how much disease you started out with to begin with, which is prognostically extremely important. It incorporates cytoreductive effort and also obviously incorporates chemoresponsiveness if you got neoadjuvant chemotherapy. And for all those reasons, I don't think it's a variable that needs to be adjusted for because actually nobody knows what it's going to be when they're making an upfront treatment decision, right? It is sort of a result or an intermediate result of the upfront treatment decision. So I didn't think that it was a variable that really fit into this analysis in any way.
Excellent. So this next question comes from Tommy Meschini in the University of Insubria in Italy, and on a topic that you have previously published as well. He's asking, during your data analysis, were you able to assess a temporal trend in the use of neoadjuvant chemotherapy across centers in the United States? Did this trend vary according to the center's volume category?
That's a great question. We didn't look at that. So obviously, we've been kind of following the uptake of neoadjuvant chemotherapy in the United States using the same database very closely. I feel like we publish an updated paper about this question every 3 or 4 years. Our last paper, which came out it was just a letter in JAMA Surgery, found that finally, I think in 2020, interval cytoreduction became a more common surgery in the United States for advanced ovarian cancer than upfront cytoreductive surgery. So, the trend has been very much in favor of adoption of neoadjuvant chemotherapy in the United States, but we have not looked at that trend specifically by volume.
Okay. This next question comes from Paula Mateo here at Houston Methodist, and she's asking if in low volume centers, higher utilization of neoadjuvant chemotherapy is associated with lower odds of mortality compared to low utilization. How would you explain the fact that the curve in low volume centers plateaus as neoadjuvant chemotherapy use continues to increase?
Yeah, I mean, I think that plateau is a really, really interesting finding, and one of the unexpected findings, and particularly that plateau was only in low volume hospitals. First of all, I think eventually you would hit that plateau at some use of neoadjuvant in any setting, meaning like in the high volume hospitals, we only really were able to look out to a neoadjuvant rate of 60% or so, and we found that that resulted in about a 2% rate of or was associated with a 2% rate of 90-day mortality. How much lower can you really get 90-day mortality below 2%? Obviously can't go below zero. So at some point you're going to hit a plateau, but obviously that plateau happens, I think, earlier in these low volume hospitals. That's what these data suggest. And I think that it probably is one of two things. One is it can be confounding by patient selection, that these low volume hospitals may in fact have patients that are at such high risk surgically, that even when they get interval cytoreductive surgery, they do very badly, right? So that's one possibility, and these are not mutually exclusive. The other possibility is that any kind of ovarian cancer surgery is riskier at low volume hospitals because of a lack of expertise, right? And that while interval surgery is safer than primary surgery, that at these volume hospitals, even interval surgery should not safely be done. And this sort of is the argument in favor of people who think ovarian cancer care should be regionalized into expert centers. And that may be true even if we all do a lot of neoadjuvant chemotherapy. So that's not only something that's true for these super centers that still prioritize upfront surgery. It may be that patients are going to do better getting neoadjuvant and interval cytoreductive surgery at high volume hospitals. And I think that's particularly true in the era of heated intraperitoneal chemotherapy.
Interesting. So, perfect segue to the next question, Tommy Meschini again. And he's asking, could the observed reduction in 90-day mortality in high volume centers also be explained by the greater surgical expertise and training of surgeons who more frequently perform complex procedures? In this regard, do your findings support further centralization of advanced ovarian cancer surgery to high volume centers to improve outcomes?
I mean, I don't think the study was directly designed to answer the question, but it certainly is consistent with that explanation. I think the thing about regionalization, right, especially in a country as large and spread out as the United States, and with as diffuse a healthcare system, is it's really very challenging to imagine how that happens logistically. Like, today I drove from Boston, where I primarily work at Massachusetts General Hospital. I drove an hour and a half north to a rural state in the United States called New Hampshire to see patients because these patients are not willing, to make the hour and a half drive. I am making the drive. Now, by making this drive, I'm able to see them, and those patients who need to come down to the tertiary center for hospital, I'm able to bring them. But I think it requires really concerted efforts to make regionalization real in the United States. It doesn't just happen. There's no simple policy solution that just makes it happen.
Such a great point. Now, this question by several of our fellows: Joni Nouveau from St. John in Newfoundland and Carlotta Sabini from Milan in Italy. They ask, your data show that mortality benefit of neoadjuvant chemotherapy was most pronounced in high volume centers, which is somewhat counterintuitive to your initial hypothesis that neoadjuvant chemotherapy would have a greater impact in low volume settings with less rescue capacity. Could you elaborate on what underlying factors or institutional practice you think might explain this pattern, whether it reflects a selection bias, unmeasured confounders, perhaps a true synergy between neoadjuvant chemotherapy protocols, and enhanced perioperative care in high volume hospitals?
I mean, I just think that's a very well formulated question, and my answer is yes. I think that all of those all of those are potential explanations, and ultimately our study is a very descriptive study, right? It's not a study that's designed to tease out the causal impacts of any of those proposed explanations, and I think that's the work I think that's the work that's left to be done. And I think it's important work because I think, if it really is causal, if really higher volume hospitals are able to prevent people from dying within 90 days of surgery, that makes a very, very strong argument for regionalization. But if it is just confounding by who goes to which of these hospitals, well, you wouldn't want to make people have to drive farther from where they live just because of a spurious association. So I think it's going to be very important to help figure out which of those this is, but I don't think our study has been able to do that.
Okay. Paula Mateo, here from Houston Methodist, she's asking the preliminary presentation of the trust trial, understanding that it is not finally published yet, but nevertheless, the preliminary information reported that in expert centers with proven surgical quality, primary cytoreductive surgery followed by chemotherapy led to longer progression-free survival than neoadjuvant chemotherapy, although the overall survival was no different between the two. How do you explain these apparently contradictory results?
Well, I guess the first thing I would say it's hard to interpret for me the trust study because I haven't I haven't seen a manuscript. Um, I have a lot of concerns about how the findings of that study were presented. In my opinion, the trust study is the fifth randomized trial really to look at the same question, and I think obviously they looked at it a little bit different. They said, looking at this question at these centers with this very high volume and this validated surgical quality, but essentially it's the same question, right? As the Vergote study, Chorus, Scorpion, Onda et al. Right, it's the fifth study, and you know, in a analysis of the not primary endpoint, right, you see some evidence of benefit, right? Well, if you look at all the endpoints in all five of those studies, right, all the primary and secondary endpoints, and you look at all of those, right, you're going to, you're doing a lot of hypothesis testing. And as we all know, when we test multiple hypotheses, we don't preserve our alpha of 0.5, meaning our probability of getting at least one spurious result grows very quickly the more and more we look. So I am not convinced that the PFS difference that we saw in trust really suggests a benefit for anyone of primary cytoreductive surgery, even at a super hospital, right? Because that's not the primary finding. And because we've looked at this question of PFS over and over and over again and haven't seen the same finding, I just don't think that trust provides us with particularly strong evidence that primary cytoreductive surgery is beneficial in patients with advanced ovarian cancer. And so I don't think there's any contradiction between the findings of this observational study and trust.
Well, Alex, I'm glad to say that your words are almost verbatim on a recent debate that I had with Christina Fotopoulos about the trust trial, and exactly the point I made was this issue of the accounting for the multiplicity and confounders in secondary endpoints that by chance you're gonna end up with one that is falsely positive. So it was almost verbatim as you outlined it. So thank you. Um,
And and I will say, like, we can't do studies looking for results we want, right? If that's how we do our studies, right, then eventually we're going to find the results that we want. We have to look at our evidence in aggregate and, in as dispassioned a way as we can. And it's just my opinion. Obviously, people disagree that if you look at the aggregate of the evidence, like it doesn't make sense to me that you're going to just ignore the four other studies and say, well, the trust trials showed, right? I think you have to look at this evidence in a dispassionate way, and you have to look at all of the trials. You can't say there's only one good one because I just don't think that's true.
yeah. So now, Mathilde Del from Toulouse in France, she's asking, in your study, you reported no difference in standardized 90-day mortality or 60-month life expectancy after excluding patients diagnosed in 2019 during the COVID-19 pandemic. Could you elaborate on how you interpret these results? Do you think it could be related to an increased use of neoadjuvant chemotherapy, or rather to a decrease in surgical management due to COVID-related restrictions?
Oh, so I think let me just clarify. So one of the things that so our main analysis included data all the way through 2020, but at the recommendation of one of the peer reviewers, a good recommendation, they said, 2020 was a really abnormal year. A lot of things started happening. Is your data is your are your do your results change if you exclude 2020? And when we excluded 2020, all of our main results stayed the same. So, which is to say that we don't believe that any of the findings that we saw were driven by all the crazy things that happened during
Mm,
the COVID pandemic.
yeah. So Alex's next question comes from Mo Byrne from the Memorial Sloan Kettering Cancer Center in New York, and she's asking, these data are older, from a time when the primary cytoreduction rates were much higher. With continued contemporary data surrounding neoadjuvant chemotherapy, including most recently the TRUST trial, we become much more selective in patient selection for primary cytoreductive surgery. Do you think if this study was repeated in today's practice patterns, there would be continued improvement with 100% neoadjuvant compared to 60%? And if improvement in mortality, do you think there would be any effect in either direction on overall survival?
Yeah, I mean, I think that's a great question. Um, and I think that, you know, one of the one of the big one of the big concerns, right, has been, who do you hurt with neoadjuvant chemotherapy, right? If we just abandon primary debulking surgery, if we go to 100% neoadjuvant chemotherapy, who is going to do worse than they would have otherwise? And I think there are clearly classes of ovarian cancer patients that definitely shouldn't be getting neoadjuvant chemotherapy because we don't have any evidence to support it. So, for example, patients with early stage ovarian cancer, right, should not be getting neoadjuvant chemotherapy, right? Like there's no trials that support that, right? I think the use of neoadjuvant chemotherapy in folks who have chemo-resistant histologies, low-grade serous and mucinous cancer. I think very little rationale or evidence to support that. And so you could certainly imagine that some of these patients for whom we don't really have evidence to support the use of neoadjuvant chemotherapy, if everyone, if everyone just gave every ovarian cancer patient chemotherapy to start, that there could certainly be harm. I
Mm,
also agree with Mo that there's going to be a floor on mortality, right? There's going to be patients that are going to do really well no matter what you do. There's going to be patients that really should have no surgery ever, right? And so you're even if you get to 100% neoadjuvant chemotherapy, I don't think you're going to be able to get 90-day surgical mortality down to zero. We're not that good at identifying patients who shouldn't have surgery, and I don't know where that floor effect is going to be. One of the inspirations to do this study was to try to find that floor effect. And what's odd is it doesn't seem like at high volume hospital we found it. So it's somewhere north of 60%. Where it's going to be, I think that's a great question.
So then to that end, this next question from Mateo Lovero. Considering both your results and the evidence from randomized trial, perhaps the real question today isn't whether neoadjuvant chemotherapy works, but why we're still reluctant to use more of it. Do you think we're still using too little neoadjuvant chemotherapy in clinical practice?
I think the evidence from NCDB suggests that there are definitely centers that are using two. I mean, and again, NCDB is, behind the times by 2 to 3 years, right? It's not a contemporary database. But I do think that there probably are centers that are doing too little neoadjuvant chemotherapy. And I think that, there has been, I think, a real communication problem from leaders in the field. We just had new guidelines come out for the use of neoadjuvant chemotherapy from ASCO. And the first time I think they wrote those guidelines was like in 2000, I think 2016 thereabouts, and they just updated them. And you know, they talk quite a bit about individualized selection for patients, but they don't come out and say, look, we don't really know who benefits from primary debulking surgery. Yeah, a lot of people think that somebody benefits, but if you look at the aggregate data from trials, people who get primary debulking surgery get more stomas, more perioperative deaths, more infections, right? And they don't live any longer than patients who get neoadjuvant chemotherapy. And I think that we have been really soft on that message. I mean, the Cochrane review, that's the message. If you read the Cochrane review, you'd be doing a lot of neoadjuvant chemotherapy like I do, for most of your patients with advanced ovarian cancer. But I think if you've been just going to the SGO meetings and if you've been reading the guidelines, it suggests that there's really a lot less certainty about this point than there is. And, I think that hopefully with the negative trust trial, we are going to be moving past that time. And I do think that, the vast majority of patients with advanced ovarian cancer are going to benefit from neoadjuvant chemotherapy. And there's very little evidence for truly patients with, who clearly clinically have advanced ovarian cancer that you're harming anyone by giving these patients neoadjuvant chemotherapy. And this notion that, if they're upfront debulkable, that you're going to make them live longer by debulking them and hurt them with neoadjuvant chemotherapy. I just don't see any empirical evidence to support that notion.
Great. So, Alex, thank you so much, of course, obviously, for your time. We just have a few more questions. Really enjoying your perspective on this. This question comes from Zaniru Marin in Mexico. And he's asking, the findings highlight disparities related to hospital experience and resources. What strategies could improve access to optimal ovarian cancer care and ensure that patients treated in these low volume centers can still achieve good outcomes, comparable outcomes?
Yeah, I mean, I think that's such a great question. I think that's a question that, in the way it's framed, acknowledges the reality that there's still going to be patients that are not going to the metropole and to the tertiary care center. There's going to be patients that are out in the periphery getting care in the locations closer to them. And I think, in certainly in my career, I have seen the model really change in the United States. More and more gynecologic oncologists are traveling to where the patients are, and they're bringing their expertise to the community, and they're meeting with with the medical oncologists, who often are the ones that are giving chemotherapy there, and we're educating them, and we're trying to start tumor boards out in the community. And so I think a really robust outreach effort, one that utilizes telehealth, right, is going to be really, really essential to trying to optimize outcomes for patients who are seen in centers that have less experience with these uncommon diseases.
Okay. So, Alex, last question from our fellows, Matilde Del, and she's basically asking, after completing this study, were there any thoughts where you said the obvious next study will be this? Where are you going from here as it pertains to this topic?
Yeah, I mean, I have been. I would love to kind of put this topic to bed. To be honest, I've been writing papers about the use of neoadjuvant chemotherapy since I was a resident, with the sort of and my conclusion frequently from looking at data in the U.S. has been like we really underuse neoadjuvant chemotherapy. What I'm seeing is that as Mo points out, like we are changing. Fewer and fewer patients are getting upfront debulks, and I think the patients who are getting upfront debulks are becoming the kinds of patients who are the ones who are safer to do that operation in. Younger patients, patients with less disease who aren't going to require the surgical radicality. And so, I guess my hope is that we can move the research agenda into unanswered surgical questions. Like I feel like this question of neoadjuvant chemotherapy, we have done a great job as a field answering it. I want to know, I want to know the role of high tech in recurrent ovarian cancer, right? We just had a fascinating study come out and suggest that there may be a role, but it's so different than the usual paradigm. How do you square chipboard with desktop, right? Like I'm really, really interested in those kinds of questions. I think they're great open questions, and I'm hoping that we can all finally agree that most patients with advanced ovarian cancer should just get neoadjuvant chemotherapy, and maybe we won't have to study it anymore.
So, Alex, as a last question, as you know, it comes from AI. When AI read your paper, this is the question that it came up with. Given that high utilization of neoadjuvant chemotherapy in low volume centers still fails to achieve mortality rates comparable to high volume hospitals, are we inadvertently legitimizing a lower standard of surgical care for patients who lack access to specialized high volume institutions?
I mean, I don't know that I don't like, I don't know that we can control the fact that patients are ending up in these low volume hospitals, right? Like, you read these amazing projects from the Scandinavian countries where they truly are able to centralize ovarian cancer care into a couple hospitals. In the United States, with our completely fractured system of paying for medical care and you know, the government involved, nonprofits, for profits, the healthcare system is just so fragmented. I don't think that as it is today, without a radical overhaul of healthcare in America, anyone could do anything to prevent patients from ending up in these low volume hospitals. So I don't know that we're legitimizing a lower standard of care. I think it is possible that the kind of healthcare system that we have built or let grow here in America is one that certainly allows for people to get completely different standards of care depending on where they end up. And I do think that that's a problem, not just in gynecologic cancer, but just across our whole healthcare system.
Well, Alex, thank you very, very much for your time, for this discussion. As I mentioned, I always learn so much from speaking with you. Thank you for everything that you have published on this topic. I mean, really, really great work. And again, of course, obviously, we continue to look forward future academic productivity from you as well. And thank you again for all that you do and have done for the journal.
Oh, thank you so much, Pedro. I really appreciate your interest in this paper, and I always love being on this podcast. And thank you so much for having me.
All right. Well, safe travels and thank you and happy holidays.
Happy holidays.